Welcome to AETCM. Today we're going to discuss a case about a 25-year-old female who was brought into our ER with history of fever with joint pain for about 6 days. She was a primi gravida. So, shall we begin?
Okay.
So the patient was primi gravida, 35 weeks of gestation with 35 weeks with 6 days.
Okay.
So initial assessment, patient was conscious but drowsy and arousable. Obeying commands and able to complete one full sentence.
So, what is the first investigation you do in a pregnant lady who is drowsy? Immediately. Yes. You have to look for the sugar. That is a commonest cause for drowsiness in any patient, including pregnancy. Okay.
How will you position the patient while you are receiving the patient? What is the most important thing?
Positioning of patient.
Position. What
Left
position?
lateral. Left lateral.
35 weeks gestation. You told, no?
Left lateral
30.
position.
Yeah, left lateral. Why?
Because uterus will be huge and it will be compressing over the aorta cable vena
Aortic
cava.
cable syndrome, occlusion syndrome, aortic cable occlusion syndrome, which will cause hypotension. The hypotension, it will reflect on the baby circulation as well as oxygenation. Or else baby will go for fetal distress.
So, in ER, what do you do? Left lateral position is not a very comfortable position for the lady. What will be the more comfortable position for the patient? Other alternative. It's an alternative by can be given from our side. That will be a comfortable position for the patient.
Really the tilt can be given. So you place
Slight
a
tilt
pillow
a pillow. Slight tilt towards the left side. I can keep a pillow. That will be the most comfortable position for the patient. Left lateral position is ideal for a patient who is having shock. Okay. Here, all patient who come to emergency room, we can give a pillow on the left side, so that patient will be comfortable and it will not lead to hypotension, shock, all these things.
Immediately you position the patient and start administering oxygen, supplementation. Okay.
Airway was patent, sir. No secretions was.
What are the airway changes you see in pregnancy? That is very important for a ER physician, because you may be anticipating some problem in this patient. So, what are the airway changes? Normally, you can see lot of changes can occur in almost all systems in the body. So, this may be required for your intubation, ventilation, all these things. Sir.
Yes.
the mucosal edema. Generally, all the soft tissue in the oral cavity, including the larynx, there will be slight edema of that.
Edema.
Larynx, everything there will be little edematous.
And enlarged.
Plus
Tongue
enlarged.
will be enlarged. Okay.
All these things are very important.
Pardon?
Friable also. Mucosa, so
Usually
it
bleed.
can also
Okay.
cause excessive bleeding.
Okay.
Hyperemia can be there. Increased secretions.
So, post intubation, you
saliva-
can bleed. Patient can bleed. You should be very careful.
Increased saliva. All secretions basically will be increased and
Pregnancy induced nausea, vomiting.
nausea, vomiting.
In the last time stress, it will be occurring. So aspiration.
Okay.
So the
diaphragm can elevate.
glottic opening will be narrow. So we have to select a little smaller size tube rather than the regular.
So these things are very important, because we are handling a pregnant lady. We should know the anatomical and physiological changes in that lady, and only you can handle the patient well. Okay.
And sphincters will be lax.
Okay. So what
Reflux
happens?
Will be,
So there will be regurgitation, chance of regurgitation during intubation, aspiration, everything is very high. Chance of complications are very high because of the physiological and anatomical changes in the lady. So we have to be very careful. Okay.
Coming to breathing, air entry was bilaterally equal. Normal vesicular breath sounds were heard. Respiratory rate of 22 per minute with saturation of 100% was maintained in room air. And in circulation, BP was 120 over 70 mmHg with pulse rate of 67 per minute.
So when we are talking about circulation in a pregnant lady, this alone is not enough. What else is needed?
Pediatric, babies circulation.
MAP is good, that is enough, but
Fetal
fetal heart rate is very, very important, because before the onset of pregnant ladies changes, you can get it in fetal heart rate. So fetal heart rate may increase. All these things are very important. So you have to comment when you are writing the case sheet there itself. No need to go for separate examination. Okay.
And we put a 20 gauge cannula on right metacarpal. So, sir, disability She was GC score was E4 V5 M6 with
E4, E5, M6. Okay.
pupil of 3 mm equally reactive, and exposure temperature of 98 degree Fahrenheit with GRBS of 108 milligram, and patient was covered to prevent hypothermia, sir. And adjuncts to primary survey, GRBS of 108, and ABG showed lactic acidosis with lactate of 7.6, sir, with, creatinine of 0.87 and bilirubin of 4.9.
Okay. Why the lactate is elevated? What are the reasons for elevated lactate here?
Hypertension,
Hypertension. One of the most important thing is hypertension. What is the BP here?
VP of 120 or 70.
Well, BP is normal. Then, what are the other reasons for
Hypoxia
hypoxia? Then,
or
what is the
liver failure.
saturation here?
Full, sir, 100%.
It is normal. So you have to roll out one by one there itself, because it's a very precious thing. Pregnancy itself is a very important condition. Okay, so you are handling two lives. So your saturation is normal. Next is what?
Sepsis.
Sepsis. Is there any sepsis here? Sepsis produces lactic acidosis because of shock.
Mitochondrial
But there is another condition, sepsis as such itself can produce
increased lactate.
mitochondrial problem and lactate. There are two types of lactic elevation here. One is due to hypotension as such. Other one is the intracellular problem. Okay,
Pyruvate.
so sepsis can produce lactic acidosis without hypotension. Okay, that is one possibility. Then
Then
liver disease. Okay, you have patient who is having pregnancy, patient is having elevated jaundice, then lactic acidosis. So liver disease can also produce lactic acidosis. Then
that renal failure can produce. No, renal failure.
failure normally will not produce
That metformin. That's it.
What is HELP syndrome?
HELP syndrome.
Elevated liver enzymes, low platelet counts with hemolysis.
So when do you suspect this one? In what term?
Patients, basically, it's a complication. Generally, it is seen in third trimester, sir, wherein the patient will have increased, deranged LFT. Bilirubin levels will shoot up because of hemolysis. Then SGOT, SGP, transaminitis will be seen. Along with this, patient will develop thrombocytopenia. So that's where, and it is life-threatening condition, so it has to be addressed right away.
Very
Patient
commonly
is going to
associated with preeclampsia.
hypertension.
What is the BP is normal
BP
here.
is normal, sir. And
So with this BP, normal BP, can we take it granted that the BP is maintained normally, or any other thing do you suspect?
If a patient has had high hypertension or high BP,
Hypertension or preeclampsia, he may be taking in some drugs, anti-hypertension. Because of the drug also, presently the BP may apparently look normal.
But is she on one drug?
No,
Any
sir.
drug?
No.
Okay.
And in secondary survey, coming to secondary survey, she was a 24-year-old female, primary gravid of 35 weeks and 6 days with no known comorbidities, complaints of high-grade fever which was acute in onset and continuous with joint pain and vomiting vomiting which was for 4 episodes, and she also had loss of appetite with decreased oral intake and having burning pain in epigastric region. And she also complained of decreased urine output also with gum bleeding. And for this, she was taken to a nearby hospital, and where she was managed symptomatically for the same.
High degree fever in pregnancy, who is having liver disease. What are the other possibilities other than HELP syndrome or cholestatic jaundice, fatty liver of pregnancy? All these things can. Hepatitis. Okay, viral hepatitis. That which is more dangerous? Hepatitis E is more dangerous in pregnancy. Okay, but in other conditions, hepatitis E is a very mild problem. But pregnancy, it is a dangerous problem. Mortality rates are very high. Then, other than that,
Drug induced.
she is not on any drug. Middle-dopa is one drug which can produce liver disease. Like middle-dopa is used for hypertensive management. Nowadays, we don't use it routinely, but still many physicians give middle-dopa. That can produce some hepatitis. Paracetamol overdose. Then,
ischemic hepatitis, etc.
why we are thinking about ischemic hepatitis?
Let's just say if the patient has any other like cardiac issues or
If
something.
the patient is having cardiac failure or cardiac arrest, then we can
Secondary to ischemic
secondary to ischemia. But here the problem is not there. But other infections Other than
Sepsis.
other infection, which are other common infection we see in our state nowadays.
Dengue.
Dengue. Dengue is the most common infection. Dengue and leptospira is the most common infection which can involve liver also. Okay, so that we have to think. Hepatitis, any type of hepatitis, including hepatitis E, dengue, leptospira, Handa fever. So many fevers are there in our state. Okay, so we have to rule out that also because high degree fever is there. And whether the patient received paracetamol, that is also very important. For fever, was she given high dose of paracetamol from other hospital? That also we should know.
So from the other hospital, she was managed symptomatically, and they had checked the lab investigations. From it, they found that platelet count was very low, sir. And for the it was found to be 8,600 from outside. So and she was found to be dengue positive also.
Okay. Any other condition which is pre-existing can come with thrombocytopenia, high degree fever, hepatitis in pregnancy. It can aggravate during pregnancy. It can be normal or maybe dormant in previous time pregnancy. It can become a problem. What is that? SLE. SLE is the one condition which can present as a storm during pregnancy, but not in the late stage of pregnancy. Early stage itself, it can show its symptoms. There you can get a hepatitis, renal failure, thrombocytopenia, all these things. Okay.
Hyperemesis gravidarum. It itself may produce hepatic derangement.
And she became hypotensive later on, and fluid resuscitation was done, and later
So
her
in a patient who is a term pregnant, hypertension, how do you manage? What is the first thing you do?
You have to first see whether it is hypertensive emergency or
Hypo.
urgency.
She was. He went to hypotension.
hypo.
Hypertension.
How do you
fluids,
manage?
IVC.
One thing, rule out supine cable syndrome. Like,
That is the most important thing. Any patient who is lying down straight, put the patient in left lateral position. The first thing we have to do in hypertension is that. Okay, how do it help?
Basically the hypertension is happening because of aortic cable compression, sir. So once the patient's heavy uterus is pushed to one side, then the aortic cable compression won't happen, and it will increase the preload, and preload increases the cardiac output.
Okay, so
increasing
first
the
thing is
PV.
always put the patient in left lateral position. So it improves the preload. It increases the circulation from the IVC.
venous return will be.
Venous return will increase. Then it also decreases the load on the aorta. So the circulation will improve. So you have to try that first. Okay. Then only our fluid resuscitation. Okay.
And later on her LFT levels were
After
getting
that, we put the patient on left lateral position.
okay.
What is the next thing? Fluid. How do you give fluid?
Fluid initial we can give 1 pint bolus, sir.
What do you follow? What do you monitor in this patient?
We'll have to check for the urine output, and then lactate clearance in this case, and also for IVC, collapsibility of the IVC. These would be the indicators, and also for see if the signs of dehydration is there, like tachycardia, any dry mucosas, sunken eyes. All of these signs of dehydration has to be seen.
So you have to carefully give fluids because pregnancy is a condition where there is a physiological fluid overload. Okay, that is there, and there is reduced reserve for all the organs. Okay, so you have to be very careful when you are giving fluid. That's all. Okay, you can give fluid by monitoring the patient very well. You can give a lot of fluids, but initially you give 1 liter of 500 ml of normal saline and see whether the patient is going to pulmonary edema or not. If it is not there, you can give more fluids. Okay.
And later on her LFT levels were getting deranged with elevated transaminase and was started on oral N-acetylcysteine. And also
What is the alkaline phosphatase in this patient? Is it important?
sir, can be
Cholestatic
Any
jaundice.
obstruction can
Any
cause
obstruction or cholestatic jaundice, alkaline phosphatase will be threefold elevated. What is alkaline phosphatase here?
the LP
186.
186. So that is not very much elevated. It's slightly elevated. That rules out mostly cholestatic phase of any jaundice. Okay.
So later on she was started on antibiotics also.
Now, what is anti hepatic it's not hepatic protective drugs, it is hepatic encephalopathy
And
drugs.
protection.
How do you give?
We can for hepatic enzyme protection we can to prevent constipation and to prevent high ammonia we can give stool softness syrup lactose can be given.
But she's having vomiting. How do you manage it?
Mm,
She's having severe vomiting.
yes.
What do you do?
Enema can be.
So enema is the answer. Okay, if this patient is having severe vomiting, we cannot give lactose syrup. You have to give lactose retention enema.
Enema.
That is a possible thing. So that has to be given. Then
Then
what
then
antibiotic you want to give for gut sterilization?
rifaximin.
Rifaximin. Is it safe in pregnancy? It is a non-absorbable antibiotic.
Yes,
It has to be safe.
Locally.
Then
Then again we can to prevent
how do you advise the diet? You have to give diet. She's a pregnant lady. She's having vomiting.
first dry.
Small
Like
frequent
small-
feeds.
small
Okay,
frequent
just see whether
feeds,
she is
right?
tolerating or not. Okay, so small feeds are needed, and you have to control the hypoglycemia. You have to give dextrose. Continuous dextrose infusion is required in pregnancy with vomiting and dehydration, all these things. Okay, so that has to be given on one side. Other side, you have to give fluids because if she is having hypertension, more normal saline ringer lactate. Can you give ringer lactate in this patient?
Can give
One
but
is
the amount of
lactate is
lactate
high,
won't
so-
cause.
But this patient is having hepatitis.
So lactate clearance will be
So
reduced.
clearance will be reduced. So you have to be very careful when you are giving ringer lactate. You can give normal saline. Okay. Then PTINR is elevated.
PTINR was
How much?
also elevated. PTINR was PT of 36 with INR of 3.
INR is elevated. So what do you think? There is a bleeding tendency.
Bleeding
I
tendency.
think DAC also has to be ruled
Ruled
in
out.
these
PT,
patients.
APTT,
APTT was
fibrinogen.
fibrinogen of 140, sir.
Fibrinogen is slightly elevated, but pregnancy it is very high. Normally it is very high. Here it is only 140. 150 is normal cutoff range. Less than 100 is dangerous level. So what else you can give other than FFP? Cryoprecipitate. So you have to give FFP with cryoprecipitate because acute liver injury, bleeding tendency is there. You are not planning for liver transplant. Okay. So it's mostly it will be a reversible condition. Once you do cesarean and delivery, it will come back to normal. So this condition before doing surgery, you have to correct the bleeding problem. You have to give FFP and cryoprecipitate. Okay. Then platelet count.
Platelet count was on 62,000.
So it is low.
Yeah.
Okay. So the patient is going to DIC now. Okay. If you don't do the delivery fast, patient will develop serious complications.
And she was also given injection vitamin K and IV and acetylcysteine to prevent with antibiotics to prevent hepatic engulf.
Okay.
And later was taken to our hospital for further management. And
What type of liver disease vitamin K will be helpful correcting the coagulation pathway? What type of?
Jaundice.
It's only in obstructive jaundice. Other condition we just give. It is not having any major role. Okay, but it can be supportive. It is not a definitive treatment.
and the environmental social history, she was coming from Maldives for the management of the same.
Okay.
Then in general examination, she was a thin-built lady, well-nourished, and there was pallor and icterus present. And LMB was on
HP person is how much?
HP was 12, sir.
But that produces pallor. Difficult. Okay, maybe because of hypotension.
And BP of 110/60 with the pulse rate of 80. Saturation was maintained at 98%. And in systemic examination, CNS, she was conscious but drowsy. And
Is there any flapping tremor or not? That is
no,
very-
sir, no flapping tremors.
Okay. Is there any altered sleep rhythm?
No altered
These are the
sleep.
two things you have to examine. One is altered sleep rhythm. Second one is flapping tremor. Okay. Because emergency room, we cannot do all systemic examination properly. You have a patient who is having pregnancy, he is having liver disease. First thing you have to rule out is hepatic encephalopathy.
and there was no signs of hepatic encephalopathy was noted.
Okay.
Later on, we also tried to prevent hepatic encephalopathy by the following
Okay.
IV antibiotics and enema. So
Okay.
later on, lab parameters were sent and which showed elevated CRP of 24 with total count of 10,000 and platelet count 62,000, and creatinine was normal, sir. SGOT was of 2,700 with SGPT of 1,400.
What are the conditions you get SGOT, SGPT elevation in thousands?
Acute hepatitis.
Viral hepatitis.
Viral hepatitis.
Okay, then
Any cirrhosis, long
all in hundreds. See, thousands there are very few conditions. One is viral hepatitis. Second thing is toxic hepatitis like paracetamol, rat poisoning, all these things. Third one, ischemic hepatitis. So these are the common conditions which can elevate SGOT, SGPT in thousands. Okay, but whereas in dengue, leptospirosis, and so many other viral fevers, it will be in hundreds. Okay, thousand means we have to be very careful. Okay.
Then LDH was of 1,800 with
LDH indicates what?
hemolysis.
It indicates hemolysis. Okay.
then bilirubin of a total of 4.4 with direct of 2.5 and a protein of 5.3 with albumin 2.6 and globulin 2.63. ALP of 186 with
Albumin is very low. This patient never had hepatitis in the past.
no, correct.
What it indicates?
Uh,
What it indicates?
Proteinuria.
proteinuria.
Is having proteinuria?
Yeah. Albumin loss.
Is there?
Hypoalbuminemia.
Is there in this patient? Is there? If it is there, then that is the reason. Otherwise, dengue is positive, albumin is low. What is the most important?
It is a negative inflammatory marker.
It's a negative inflammatory marker. That means the low albumin indicates high inflammation, and that is due to the blood vessels are damaged. Okay. Here the blood vessels are damaged. Through the blood vessel damage, protein has gone out. Where else it will go? If there is proteinuria, it has to go through the kidneys. But if it is not there, then you have to be very careful. This patient will become deteriorate very fast. It is called as negative inflammatory markers. Whereas CRP, ESR, ferritin, all are positive inflammatory markers. Albumin is a negative inflammatory marker. That means low protein, low albumin indicates a severe inflammation in your body.
Okay, sir. And later on, she was stabilized and she was immediately shifted for LSCS.
Okay.
And
So that is a definitive treatment. We should not waste our time. LSCS is the definitive treatment here. Only thing we have to correct the bleeding parameters here. Okay.
and following the LSCS, she was becoming normal with all her counts becoming normal.
So when you are taking this patient for LSCS or any procedure, how do you give drugs? These drugs are very important because patient is pregnant and she is already having liver disease. Okay, so you have to tell about that.
Yes.
Regarding the anesthetic drugs, induction agents, sedative drugs, muscle laxants.
We had to give the liver protective drugs, sir, and also
Yes, sir is asking anesthesia drugs, induction agents, and pain management in a pregnant lady with liver disease with a probable hepatic encephalopathy.
As a pre-medication drug, sir, for pain management, any opioid can be given, provided along with this, constipation has to be kept in mind. But with small doses, constipation is unlikely to be caused. So for pre-medication, along with pain management with fentanyl, anti-secretory agents like glycopyrrolate can also be
What
given.
about other agents like morphine, pectidine?
Morphine can also be given, sir.
So we are going for a cesarean, so that will affect the baby's respiration.
Respiratory
Okay.
depression.
So you select any agent which can have a reversal, naloxone or nalorphine, like that we can select it. Fentanyl is a good choice, no problem. Then
Anti-secretory agents.
the anti-secretory whenever necessary. Okay, good.
So this would be the pre-medication part.
So what about induction agent, propofol, ketamine?
Ketamine, depending upon the hemodynamic status. So if the patient is tachycardic or hypertension, then ketamine is generally not the preferred agent. So in that case, we go more for etomidate because it will not cause any hemodynamic instability. But problem with atomidated is it will cause cortical suppression, that
Adrenal
cortisol
cortical
suppression. But
Already patient is having hypertension.
hypotension. So, but etomidate can still be tried with some, and
What about
propofol again
propofol?
it will worsen the patient's hypertension.
See,
Propofol.
the most important thing, avoid hypoxia and hypotension.
Hypertension.
This will again worsen the liver function. So it is avoiding. So propofol is not an ideal choice. Ketamine in lower dosage, it is okay. So unless the patient is having high BP already, otherwise we can give it. Okay, when you are using ketamine, fentanyl dosage can also be reduced. Good oxygenation and all precautions regarding the airway changes and intubation and positioning, and always keep the suction ready. So the most important thing is the gastroparesis. See, even for 12 hours to 18 hours and all, we have seen patients vomiting the previous food. So that much prolonged period, and solid food may also be vomited. We have to be okay. Then regarding the muscle laxants,
Atracurium, cetracurium can be used, sir, because it will have Hoffman's degradation.
very good.
So,
Self-degradation.
It will not go
Hoffman's,
through the
okay,
liver.
good.
so any other than that, other agents depending upon the liver status, other non-depolarizing agents like rocuronium, becuronium can be given, but the doses has to be reduced.
Reduced, okay.
Yeah. Ultimately, what happened to the patient?
Patient was after the delivery, the liver transaminase level were getting reduced, and she was getting stabilized. And
So you think that it is dengue fever?
dengue.
It has
Cannot be
caused-
dengue. Okay, because dengue, if it is due to dengue, the liver enzymes will not come back to normal by delivery. Second thing is dengue. Normally, it will not elevate STOT, SGPT in this level. Okay, either it has to be viral hepatitis or drug-induced hepatitis, or it is a problem within the pregnancy, like HELP syndrome or whatever it is. We don't know. We are not an expert to tell about the diagnosis.
Have been undiagnosed
And
preeclampsia
okay,
can also.
so that may be the reason. Otherwise, we have to prove it by liver biopsy. That is not possible in our country. Every patient who is coming with a liver injury, we cannot take liver biopsy. Okay, only thing we can manage the case without any complication, because here the problem is patient is having liver injury. We have to give drugs which prevent hepatic encephalopathy. Patient is having bleeding tendency. Before surgery, we have to correct the problem in PTINR and APTT should be corrected. Here, fibrinogen levels are relatively low. That you have to think, because pregnancy, if you take normal pregnancy, fibrinogen levels are very high. Here it is towards a lower limit, so you have to correct with FFP with cryoprecipitate. And antibiotics are required to prevent hepatic encephalopathy, and post surgery also you will have to give antibiotic. Okay. So anything else you want to tell?
So basically, a patient like this coming. So basically, we have a pregnant lady coming with acute liver failure. So initial care of management, like initial assessment, we assess the patient from A to like A, B, C, D. Airway, actually, she's somewhat okay. Breathing part, we have to supplement
But
oxygen.
even if airway is normal, you have to anticipate any problem.
Anticipate, yeah.
Because this patient will be taken for surgery during that period. It can produce a problem.
So especially in females, if you're going for like rapid sequence intubation, we have to be careful about the positioning of the patient. Either it has to be left lateral, or we have to like supplement some pillow or something below the level of shoulder to properly position the patient. And also we have to think about apnea, sleep, this thing. Apnea ventilation, this patient will be much lower because of the gravid uterus is about 36 weeks. It will be presenting over the diaphragm. So like unlike a normal patient who will be having about 5 to 8 minutes of apnea time, this person should be intubated within less than 3 minutes. So we can even go for like we can put a high flow nasal cannula even during the apnea time, intubation time also. So apnea time will be reduced. So we have to minimize the positive pressure ventilation. So as long as the patient is tolerant, and we can continue with a high flow like NRBM or BiPAP, whichever she is actually already on, even while during giving the induction agent. And once she is sedated, only we immediately remove the mask and go for intubation. So positive pressure should be avoided as much as possible. And then the next step will be breathing. If supplement options is required, we can go for supplementation. Then circulation part, if the patient is hypertension, we have to initially rule out any supraincaval syndrome, and then we have to go for initial fluid resuscitation, and the next will be like to assess both the mother and child circulatory components, and then we start for NORAD or other supportive medications as early as possible. And then again, especially in this patient, actually, she is in high prone chance for hypoglycemia secondary to hepatitis, and also she's having profuse vomiting. So initially, we can keep her on NPO and
You
start her
want to
on
give thiamine in this patient?
thiamine can also be given.
It has to be given,
Given,
because severe vomiting in pregnancy is the most important cause for
Hmm.
Wernicke's encephalopathy.
So continuously vomiting patient, we can actually start her on keep her NPO and start IV fluids including dextrose, and slowly start on
Because we are
fluid
giving continuous dextrose, that with the severe vomiting can produce thiamine deficiency.
thiamine deficiency. So thiamine plus glucose can be given, and slowly we can start with liquid diet, and then slowly start on soft diet, and then on solid diets. So that will be the nutrition part, and then will be anti-encephalopathy measures, which we can promote a few frequent loose stools, like 2 or 3 loose stools per day, and also start on a prophylactic antibiotic, both intra-gut and also systemic antibiotics can be given, and then will be to watch out for coagulopathy, because patient already have elevated INR, which we have to correct before surgery. And also platelet should be corrected at least above 50,000 before surgery. Even if you're planning for an emergency LSCs, we have to bring it up at least above 50,000. So we can give emergency FFP or this cryoprecipitate transfusion. Along with that, we have to give platelet transfusion also. HB is okay in this patient, so correcting these components, we can take her for LSCS. Next will be a continuous hemodynamic monitoring, because anytime she can worsen her status because of this elevated worsening liver failure. And also we have to avoid whichever drugs which can actually again worsen the condition. Even paracetamol and all other simple analgesics can also be avoided if possible, because already her LFTs are in thousands. Next will be continuous tachographic monitoring for the baby, which should be initiated as soon as the patient arrives in ER until the child is delivered. So that will be the primary basic management of this patient. So currently, patient is actually underwent LSCS, and post-op she's recovering very well. Left everything is coming back to normal.
So one thing, when you are planning or anticipating a immediate surgery, better keep her NPO. So all only by IV fluids, and not necessarily you can plan for pre-oxygenation. Sooner the patient is coming, the oxygenation part should be taken care. That's what the main important thing is. The apneic interval will be very short. So within that we should intubate and connect her to the ventilator.
Okay. Thank you.